Hi dear friends, I am Dr. Pankaj Tikku. I am pediatric faculty on eGurukul and at Dr. Bhatia Medical Institute, and I welcome to this high yield FMG questions platform where we'll be discussing 10 high yield questions. So these questions have been taken from topics which I feel are very important topics for your examinations, and we'll be discussing those 10 questions, and along with the questions we'll be discussing about the explanations and topics which are related to those questions. The idea is to make you well prepared for your FMG or FMG examination. June 2022 examination is now around the corner, and the idea is to discuss those 10 questions, 10 important topics which are very important from the pediatric point of view. Let us start with the first question, which is a question on developmental milestones. So developmental milestones are a very important topic from your examination point of view, especially milestones which are gross motor and fine motor milestones. Although language and social milestones are also very important, but you should particularly be very attentive and should have good amount of knowledge about the gross motor and fine motor milestones. Fine motor milestones, we also call them as adaptive milestones. And I've discussed in my classes about these four subcategory of milestones: gross motor, fine motor, language, social. So this question says, which of these milestones shown in the option is the last to appear in a child? So to answer such type of questions, one should be well aware about the timing of the appearance of different milestones in a child. And if you are able to answer which is the milestone which appear at a particular time, then from the options you can very easily decide which among these is the last to appear, or even which of these is the first to appear in a child. Or sometimes they might ask you a sequence of the development of milestones. So they may give you four options and they may ask you these milestones, they develop in what sequence. So any of these type of questions can be asked: the first milestone to appear, the last milestone to appear, or the sequence in which the milestones appear. And these questions can be very easily answered if you know what is the timing of different milestones. So when you are going for these exams, especially from the pediatric point of view, please be very familiar with the timing of different milestones in a child. So the question is, which of these milestones shown in the option is the last to appear in a child? Now, first milestone is making a tower of 6 cubes. The second milestone is climbing stairs. The third milestone is copying a circle. And the fourth milestone is complete bladder control. So in my classes, I very clearly told you the timing of appearance of these milestones. A child is able to make a tower of about 6 to 7 cubes by the age of about 2 years. So the child can make a tower of about 2 cubes from the age of 15 months. He puts one cube and he puts another cube over the first cube. So he can make a tower of 2 cubes by the age of 15 months. He can make a tower of about 6 to 7 cubes by the age of 2 years. And he can make a tower of about 10 cubes by the age of 3 years. Then climbing stairs. Most children are able to start climbing stairs again starting from the age of 2 years. I've told in my classes that although a child can creep on stairs at the age of about 15 months, but he starts climbing stairs only from the age of 2 years. So at 15 months, he'll start creeping on the stairs, but he starts climbing on stairs only from the age of 2 years. And his climbing at 2 years is different from how we climb the stairs. So at 2 years, he first puts one foot on a step, then puts another foot on the same step. So he climbs one step at a time. Then next step, he puts one foot on a step, then puts another foot on the same step, then moves to the next step. So the child is climbing one step at a time. So he goes upstairs and downstairs one step at a time at the age of 2 years. By the age of 3 years, he starts walking a little more confidently on stairs, especially when he's going upstairs. So when he's going upstairs, he actually can move alternate foot per step. But while coming downstairs at 3 years of age, he still moves very slowly, putting both the foot on each step. And finally, at 4 years, the child can walk like we walk on stairs, going both upstairs and downstairs, alternate foot per step. But the child can start climbing stairs from the age of 2 years. Then copying a circle. A child can copy a circle at the age of 3 years. Again, in my classes, I've told a child can copy a line at the age of 2 years. Then he can copy a circle at the age of 3 years. He can copy cross at the age of about 4 years. He can copy squares or rectangles at the age of about 4.5 years. And he can copy a triangle at the age of 5 years. He can copy 6-sided figures like a hexagon at the age of 6 years. He can copy a rhombus at the age of 7 years. And he can copy cylinders at the age of 9 years. So as the child's age is gradually increasing, the maturity of the hand drawing of the child improves, as is adaptive milestones. That means the milestones involving the use of grasp improves. The last option is a complete bladder control. A complete bladder control in a child is achieved at the age of 5 years. A complete bowel control in a child is achieved at the age of 4 years, but a complete bladder control in a child is achieved at the age of 5 years. So children before the age of 5 years may partly or sometimes occasionally keep bedwetting either during the day or during the night. But most of these children are usually dry by day and dry by night by the age of 5 years. That is the reason why you should never make a diagnosis of enuresis before the age of 5 years. Enuresis is bedwetting, and you should never make a diagnosis of enuresis before the age of 5 years because bedwetting is common in children below 5 years of age. The younger the child, more likely the child will be having the habit of bedwetting because the bladder control gradually improves over a period of time. The best treatment of enuresis or nocturnal enuresis in children is usually a conditioning therapy or a bell and alarm therapy. So a non-pharmacological treatment like a conditioning treatment or a bell and alarm treatment is the first line treatment that you normally will give for a child, and usually most of these children are successful in achieving short-term bladder control on conditioning therapy. Pharmacological treatment is usually reserved as a second line treatment, with desmopressin taken as usually the first line pharmacological treatment for nocturnal enuresis. Oral desmopressin is what we normally prefer, not nasal desmopressin. Nasal desmopressin has been known to be associated with significant side effects. So oral desmopressin given about 2 hours before bedtime is what is recommended as the first line pharmacological treatment of nocturnal enuresis. If this is not successful, then second line treatment, pharmacological treatment after desmopressin can include anticholinergic agents like tolterodine or oxybutynin. And if this is also not successful, then one may go on for a third line treatment, which actually should be reserved as the last line because of the significant amount of cardiac effects which can be associated with this treatment. And this third line treatment is usually drugs like imipramine, which are actually low dose antidepressants. They are actually the drugs that can be used as third line treatments, but never to be used as first or second line options for the treatment of nocturnal enuresis. So now you have the 4 options in front of you and the age at which these 4 milestones are known to develop. And now it's very easy to tell which of these milestones is the last to appear. So the one which is the last to appear is a complete bladder control, which is achieved in a child at the age of 5 years. Now, question number 2, which is a very important topic from your examination point of view, especially for your FMGE as well as for NEET PG exams, and I've talked about this topic at length in my classes, is the topic of short statures in children. And those who have attended my classes would have known that I have discussed about short stature at length in my growth and development chapter. And this is a question which is a question discussing about short stature differential diagnosis and subtypes of short statures. So question number 2 says a short stature child is brought to your OPD for evaluation. The past history of the child along with the medical record evaluation reveals that the child has a normal growth velocity and the bone age of the child matches with the chronological age. So they're asking which of these is the most likely cause of short stature in the child. The options that they have given are a constitutional delay, a chromosomal disorder which led to a short stature, a small for gestational age, or a familial short stature. Now, in my classes, I've discussed that short statures in children is divided up into two broad categories. The first type of short stature in which during the major part of childhood, the growth velocity remains normal. This is called as a physiological short stature, or sometimes it is also called as a normal variant short stature. However, the type of short stature in which the growth velocity of the child is reduced and primarily there are underlying pathologies which have led to the short stature in the child. Those type of short statures are called as pathological short statures. So two broad categories of short statures are there. Physiological short statures, which are sometimes also called as a normal variant short statures, in which the growth velocity during the major part of childhood remains normal. So understandably, there are known pathologies associated with this type of short statures. No known pathological disorders which are associated with physiological short statures. But pathological short statures, the growth velocities are reduced and there are underlying causes for this type of short statures. Physiological short statures, then I also discussed, are further divided up into two broad categories. One are familial short statures, which are short statures primarily because the parents in the families usually have short heights, and the other is a constitutional delay, which is usually associated with a reduced growth velocity only between 1 to 3 years of age usually, but usually the remaining part of childhood, the child has a normal growth velocity. In fact, the child during the adolescence grows at a faster rate with a steeper growth curve, achieving almost a normal stature in comparison to other children of the same peer group. So while in a constitutional delay, the final height usually is normal, in a familial short stature where the parents are short, the final height is short. And a constitutional delay is usually associated with a family history of delayed puberties. But there is no family history of delayed puberties which are present in familial short statures. Familial short statures primarily associated with short parents. Now, when you evaluate the bone age of the child, bone age of the child, also called as the skeletal maturation, is identifying the epiphyseal centers on an X-ray and calculating the age based upon those epiphyseal centers. So when the bone age of the child matches with the chronological age, it is more likely to indicate a familial short stature, while usually in a constitutional delay, the bone age does not match with the chronological age, is delayed. The difference between the bone age and the chronological age may not be substantial in a constitutional delay. The bone age may only slightly lag behind the chronological age, but nevertheless, there is a difference. In pathological short statures, that difference is much more substantial, with bone age significantly lagging behind the chronological age. However, the only type of short statures usually in which the bone age of the child, the skeletal maturation based upon the X-ray matches with the chronological age, is the familial short stature. So now if you come back to our question, first they have said that the child has a normal growth velocity. A normal growth velocity in a child usually means a child most likely has a physiological short stature. In a pathological short statues, the growth velocities will not be normal. It will be reduced. That's the average height that the child is gaining every year, usually, over a fixed period of time. That's what is known as growth velocity. So growth velocity is reduced in a pathological short stature. So when we say that the growth velocity of the child is normal, it usually indicates towards a physiological short stature. So therefore, all causes of pathological short statures, just small for gestational age, chromosomal disorders, they automatically are now removed. They cannot be the answers. So now my answers would either be a familial short stature or a constitutional delay, because those are the only two main causes of physiological short statures in children. Now among these, which of them is the answer will depend upon the second point, which says that the bone age matches with the chronological age. As I told you, in a constitutional delay, there is a difference between the bone age and chronological age. There is bone age, there is a chronological age, but the bone age is delayed in comparison to the chronological age. The only type of short stature in which bone age matches with the chronological age usually is a familial short stature, and therefore our best answer should be a familial short stature. Pathological short statures further are divided up into disproportionate and proportionate short statures. Disproportionate short statures can be associated with infantile disproportions and advanced disproportions, such as rickets, such as achondroplasias, such as congenital hypothyroidisms. And proportionate short statues can have many underlying causes, including endocrinal disorders, small for gestational ages, malnutrition, systemic diseases. So these are causes of pathological short statues in children. So I hope now you have understood why in question number 2, the best answer will be familial short stature. Coming to question number 3. Question number 3 is a question from neonatology. Again, it's a quite simple question, and it's basically focusing on the umbilical cord of the child. And in my classes, I've talked in detail about umbilical cord, how many arteries, how many veins are there in the umbilical cord, when does the umbilical cord fall, what are the abnormalities that can be associated with the umbilical cord. Now, this question says a newborn is brought to the pediatric OPD for developmental assessment. The mother is worried that the child's umbilical cord has become black but has not fallen. So the umbilical cord has become black and is now dry, but the mother is worried that the umbilical cord has still not fallen. Probably someone from a family or someone from the neighborhood may have given her the indication that if the umbilical cord has not fallen in a newborn, then this indicates an abnormality. Now, actually speaking, to be very frank, since the age of the child is not mentioned here, it is a little difficult to answer if it is truly pathological if the umbilical cord has not fallen. But still, considering that this child is a newborn child and newborn period is still 28 days of age, I will still give the benefit of doubt to this question and say that the child is a child who has been brought just after birth. So let us say the child has been brought just after birth. Ideally, they should have mentioned the age of the child. Then you would have been more confident in telling whether this is pathological or not. But considering that the child has been brought just after birth and the umbilical cord has not fallen, now the mother is asking that is this normal or not. So they have given the options. What will your advice be to the mother? You will advise the mother that she should seek an opinion of a pediatric surgeon to get the cord separated. Rarely is that required. Option B says she should get a routine ultrasound abdomen done to find out a co-associated congenital abdominal defect. See, co-associated congenital anomalies can be seen, but they are more likely to be seen in cases of a single umbilical artery. Normally, there are two umbilical arteries and one umbilical vein. But in case there is a single umbilical artery, you might suspect congenital genitourinary defects or congenital gastrointestinal defects or even congenital heart defects. Genitourinary defects, especially unilateral renal agenesis, for example, is quite commonly seen in these cases. But a cord has not fallen, unlikely that it will be associated with a co-associated congenital abdominal defect. I am again and again specifying that age of the child should have been mentioned here. That would have been better for us in answering the question. But I am still taking it as a child who has been brought just after birth. Third option says look for associated infection around the umbilical stump as a possible cause for non-separation, which is not the case. You might have cases of umbilical cord infections, omphalitis, but usually they are associated with redness around the umbilical stump. Sometimes they can be excessive tenderness and the child having incessant crying, pain. But that again will not be the reason usually for an umbilical cord not falling after birth. We all know that the umbilical cord normally will fall by about 7 to 10 days, may sometimes take up to 2 weeks. So even if the umbilical cord has not fallen by about 7 to 10 days, most cases umbilical cord starts becoming blackish and dry by the 2nd to 3rd day. And then it usually will fall by about 7 to 10 days. Currently, there is no recommendation to uniformly apply or no universal recommendations to apply an antiseptic lotion or antiseptic cream at the place where the umbilical cord has fallen, at the umbilical stump. So there is no recommendation that you should routinely apply an antibiotic cream or antibiotic ointment. Just keep that area dry once the umbilical cord has fallen. So according to me, the best answer to this question is that you have to just reassure the mother that the reason why the umbilical cord has not fallen in this child is that the child currently has not achieved that age when the umbilical cord will fall. And as I've told you, that age usually is around 7 to 10 days, may sometimes takes up to 2 weeks to fall. So just reassurance of the mother to not get misled by sometimes baseless facts or baseless, not facts, but baseless things that are being told by many people in the neighborhood who actually know little but probably will try to explain much, which actually does more harm to the mother than any good. So the mothers get worried in such cases, which unnecessarily, because of the apprehensions and because of the worry that the mothers have, unnecessarily will produce a impact on even the milk secretion, which is so important for the child. So the best answer here should be reassurance of the mother that there is nothing wrong in the child. When the child will be around 7 to 10 days, the umbilical cord will fall. Apart from that, there is no other need for any treatment according to me. But again, I am saying age of the child should have been mentioned. Any child 5 days age, 6 days age, 3 days age, 4 days age, less than 10 days of age, you can expect that umbilical cord will fall soon. So there is nothing to worry. Let us come now to question number 4. Question number 4 is again a topic from neonatology, which is now focusing on the temperature of a newborn. Again, a very important topic. The question says a newborn with an axillary temperature of 34.5 degrees centigrade. So an axillary temperature of the newborn was taken. It was 34.5 degrees centigrade. The newborn is having bradycardia, which in a newborn is defined as a heart rate which is less than 100 per minute. And this is definitely pathological. And the newborn is having sluggish neonatal reflexes. Most newborns, when they are cold, hypothermic, their heart rate starts falling. They might stop taking feeds or become very sluggish, and the neonatal reflexes become very slow. The child in addition also has a weak cry. So this child definitely appears to be in a state of hypothermia. Now the question is, what grade of hypothermia is present in this child? Considering that the temperature of the child is 34.5 degrees centigrade, what grade of hypothermia? So first you should know, is this hypothermia or not? Taking axillary temperature as the benchmark, we will say that 36.5 to 37.5 degrees centigrade is the normal temperature of a newborn. So the normal axillary temperature of a newborn is between 36.5 to 37.5 degrees centigrade. So an axillary temperature which is less than 36.5 degrees centigrade is called as a hypothermia, while an axillary temperature which is more than 37.5 degrees centigrade will be called as a hyperthermia. So hypothermia is when the axillary temperature is less than 36.5 degrees centigrade, while hyperthermia is when an axillary temperature is more than 37.5 degrees centigrade. Hypothermia is further subdivided up into three categories. A mild form of hypothermia, which is sometimes also referred to as cold stress. This is also referred to as a cold stress, is defined as a temperature between 36 to 36.5 degrees centigrade. To be more precise, it is temperature between 36 to 36.4, because 36.5 and below is hypothermia has started. So when I say temperature of a child below 36.5, hypothermia has already started in the child. And a mild form of hypothermia, which is called as a cold stress, is a temperature when it is between 36 to 36.4 or 36.5. A moderate form of hypothermia is when the temperature of the child between 32 to 36 degrees centigrade. Again, better would be to say 32 to 35.9 degrees centigrade, because 36 to 36.4 will be actually a mild form of hypothermia. But for easy remembering the things easily, take it as 36 to 36.5 mild form of hypothermia, which is also called as cold stress. 32 to 36 degrees, which is also called as a moderate form of hypothermia, and a severe form of hypothermia, which is a temperature less than 32 degrees centigrade. So there are three degrees of hypothermia: mild hypothermia, a moderate hypothermia, and a severe form of hypothermia. A mild form of hypothermia, which is also called as cold stress, is when the temperature is between 36 to 36.5 degrees centigrade. A moderate form of hypothermia is when the temperature is between 32 to 36 degrees centigrade, while a severe form of hypothermia, which is life-threatening, is when the temperature falls to even less than 32 degrees centigrade. So considering our patient has a temperature of 34.5 degrees centigrade, this will fall under the category of moderate hypothermia. A mild hypothermia, which is option A, as I told you, is between 36 to 36.5. And option D, cold stress. Both of them are the same. So mild hypothermia and cold stress are the same. But this child does not have a mild hypothermia, because a mild hypothermia will be defined as a temperature in a newborn between 36 to 36.5, which is not in this case. In this case, the temperature is 34.5. So it's between 32 to 36, which is moderate hypothermia. As hypothermia starts in a newborn, usually what happens is the temperature of the child starts falling. So initially the extremities of the child become cold, and gradually when the body of the child also becomes cold, it usually indicates that the child has already entered into a moderate to severe hypothermic stage. Heart rate of the child starts falling. There will be some degree of hypoxia and also increased glucose utilization, which leads to hypoglycemia also. So bradycardia, hypoxia, hypoglycemia will occur in a hypothermic newborn. Hypoxia and hypoglycemia will further contribute to pulmonary vasoconstriction, which probably will further aggravate hypoxia or hypoglycemia in the child. And this sometimes can even become life-threatening, because pulmonary vasoconstrictions, hypoxia, they all can contribute to anaerobic metabolism, metabolic acidosis, which ultimately can further aggravate pulmonary vasoconstriction, leading to even deaths of the newborn. So this question number 4, Please remember the different degrees of hypothermia according to the temperature, and in this child, the child is having a moderate form of hypothermia. Coming now to question number 5. Question number 5 is a question which actually is asking you about the manifestations or presentation of a child who is a child born after 42 weeks. Now, in my classes, I've discussed about the fact that a child who is born earlier than 37 weeks of gestation is called as a preterm child. A child who is born between 37 to 42 weeks of gestation is called as a term gestation child. But any child who is born after 42 weeks of gestation will be called as a postterm child. So our patient, newborn, has been delivered at 43 weeks of gestation. So this automatically becomes a postterm child. The question they are asking is, the pediatrician is examining this child after birth. Which of these would be the least likely expected finding in the child? Least likely finding expected in a postterm child. So when you're examining newborns, especially when you're examining preterm newborns who are born earlier than 37 weeks, or you're examining postterm newborns who are born after 42 weeks of gestation, there are certain salient features associated with preterms and postterm newborns, which again I've discussed in my classes. Preterm newborns, for example, their skin is very, very thin, fragile, often red skin. Postterm children are more likely to have a dry skin. Their skin is often dry, not thin, transparent. It has a dry skin. Another thing that is important in postterm children often is that these children often have long nails. Postterm children, obviously, because as they are staying in the gestation for longer period of time, they gain more weight, they start to have more degree of hypoxia, and because of hypoxia, they may pass meconium in utero, inside the uterus, and may aspirate that meconium, often leading to meconium aspirations. So meconium aspirations are very common findings which are seen in postterm babies. And often when these children are born, their whole body will be stained with meconium. In fact, depending upon whether the nails of the child are meconium stained or the whole body of the child is meconium stained, that can roughly indicate for how long the child has been lying in the meconium stained liquor. But anyway, it is quite expected for a postterm child often to have meconium staining and even a meconium aspiration. But postterm children are unlikely to have an excess lanigo. This is unlikely to be present in a postterm child. Lanigo are the hairs present in the fetus. They are very prominent, present on the forehead of the child, face of the child. And most of these cases of postterm children actually have absent lanigo. In fact, the lanigo starts disappearing from the fetus during the later part of gestation, and most term newborns and postterm newborns will be having no lanigo or minimum lanigo. Because lanigo, which is the hairs in the fetus, start disappearing during the later part of gestation, a preterm child who is born earlier is more likely to have an excess lanigo. So excess lanigo or excess hairs are more likely to be findings of a preterm child in comparison to a term or a postterm child. Preterms are more likely to have thin red skin. They are more likely to have sole creases which are either absent or very superficial. So the foot, when you examine a foot of a preterm child, the foot of a preterm child will actually have very superficial or absent sole creases. Meconium aspiration or meconium stained liquor or meconium aspiration syndrome is not a finding of preterm children. Preterms are more likely to have surfactant deficiencies, especially if these children are born earlier than 34 weeks of gestation. The maximum amount of surfactant production is seen at 34 to 35 weeks of gestation. So those preterms who are born earlier than 34 weeks or 35 weeks are more likely to suffer from surfactant deficiency, which leads to the development of what is known as the respiratory distress syndrome or a hyaline membrane disease. So preterms are more likely to have a respiratory distress because of a respiratory distress syndrome or a hyaline membrane disease. While postterm children are more likely to have respiratory distress because of a meconium aspiration syndrome. Preterm children, in addition, may have very small breast nodules. If you press their ears in preterms, the ear very slowly go back to the original location or original position, which is because of deficient ear cartilages. So very slow ear recoil, which is seen in preterm babies. So very salient differences which are seen in children who are born preterm and children who are born after term. So 37 to 42 weeks is the term gestation child. Without going into details, there is a scoring system which is known as the modified Ballard scoring system. And modified Ballard scoring system is a very good scoring system that is used to attain or ascertain the gestational maturity of a child. So any newborn who is delivered, the gestational maturity of that newborn, especially between 20 to 44 weeks, you can assess the gestational maturity between 20 weeks to 44 weeks using a modified Ballard scoring system. It uses certain criteria. I will not go into the details. And using those criteria, a final score is calculated. And based upon what the score is, you can find out what is roughly the gestational maturity of that child. That scoring system is known as the Ballard scoring or the modified Ballard scoring system. Coming to question number 6. Question number 6 asks the most common ischemic brain injury, which is likely in a preterm child, a premature child with a history of cord prolapse and a perinatal asphyxia. What is meant by a perinatal asphyxia? Perinatal asphyxia is any asphyxia which occurs during the perinatal period. Starting from around 28 weeks of pregnancy, continuing till around 7 days after birth. During this perinatal period, broadly, any form of interruption of blood supply to the fetus or newborn or oxygen supply to the fetus and newborn can lead to difficulty in establishing a normal crying after birth. That is called as a perinatal asphyxia. Like a cord prolapse, it can cause a perinatal asphyxia. During the pregnancy period, abruptio placentas, placenta previous, all of them can lead to interruption of the blood supply to the fetus. So it can lead to perinatal asphyxias. Basically, what is happening in a perinatal asphyxia is that the oxygenated blood from the mother to the child is interrupted. And this interruption obviously will lead to damage to different organs because of ischemia. When the brain gets affected as a result of perinatal asphyxia, we call that as a hypoxic ischemic encephalopathy. So what is that condition called? When the brain gets injured. When the brain gets injured because of that hypoxia and ischemia, we call that condition as a hypoxic ischemic encephalopathy. In short, we also call it as HIE. Now, when hypoxic ischemic encephalopathy occurs, that means brain is not getting oxygenated blood. When the brain is not getting oxygenated blood, there are different type of ischemic brain injuries that can occur. The type of ischemic brain injuries can differ in term newborns and in preterm newborns. In preterm newborns, the most common ischemic brain injury or the site of ischemic brain injury is the area of the white matter around the ventricles. So that's the most susceptible zone to ischemic injury. The area of the white matter around the ventricles. They are most susceptible to ischemia. So what happens? Necrosis of the white matter around the ventricles occurs. Necrosis of the white matter around the ventricles. That is called as a periventricular leukomalacia. Peri means around, ventricular means around the ventricles, leuco means white matter, and malacia means necrosis of the white matter. So the most common ischemic brain injury that is seen in preterms is the necrosis of the white matter around the ventricles, which is called as a periventricular leukomalacia. That's the most common ischemic brain injury that is seen in preterm newborns. In term newborns, the type of injury that is more commonly known to occur are the type of injuries which are mentioned in options A, B and C. So these injuries, rather not A but B and C, these are more common type of injuries that are seen to the brain in term newborns. So in terms, whenever ischemic brain injury occurs, often selective neuronal necrosis can occur, and this can include selective neuronal necrosis even in the cerebellar area, often leading to infarcts in the cerebellar area. There are also watershed infarcts. Watershed areas of the brain are areas of the brain which actually are not supplied by the main cerebral arteries. So these watershed areas of the brain, which are also the parasagittal areas of the brain, are the ones which are more susceptible to ischemic injury in a term newborn. So in a term newborn, the most susceptible areas which are susceptible to ischemic injuries are the watershed or the parasagittal areas. But in the preterm, the most susceptible area to ischemic injuries is the periventricular white matter area, and the necrosis of this periventricular white matter area is known as a periventricular leukomalacia. Coming to question number 7. Question number 7 says the newborn is delivered at 32 weeks of gestation and is diagnosed with a patent ductus arteriosus. So patent ductus arteriosus is a congenital heart disease in which the ductus arteriosus, which is a connection between the pulmonary artery and the aorta. So this is an embryological connection. It's an embryological connection between the pulmonary artery and the aorta. So suppose this is the right ventricle and this is the left ventricle, and this is the aorta, and this is the pulmonary artery. So the connection between the aorta and the pulmonary artery, this connection is called as the ductus arteriosus. And this ductus arteriosus normally should close after birth because of the high amount of oxygen which is present in the environment. So that high amount of oxygen in the environment is the primary stimulus for the closure of the ductus arteriosus after birth. There are other factors involved also, but the primary reason for the closure of the ductus arteriosus after birth is the high amount of oxygen in the extrauterine environment. However, suppose after birth this ductus arteriosus does not close. Anatomically, this ductus arteriosus should close between day 10 to day 21 after birth. When should this ductus arteriosus close? Between day 10 to day 21 after birth. But suppose it does not close, then this condition is called as a patent ductus arteriosus. So in this child, the newborn has a normal cry after birth, APGAR of 5 and 7 at 1 minute and 5 minutes, and is currently in the ICU. Which of these is an incorrect statement about this disorder? So we are asking which of them is an incorrect statement about a patent ductus arteriosus. Now in my classes again, I've described about classification of congenital heart diseases. Acyanotic, cyanotic. In acyanotic, I discussed about left to right shunts. And in left to right shunts, along with atrial septal defects, ventricular septal defects, atrioventricular septal defects, I mentioned about patent ductus arteriosus. So patent ductus arteriosus is actually an acyanotic disorder. So statement A is correct. B. Commonly leads to death due to heart failure. This in fact is true. Large patent ductus arteriosus lead to excess left to right shunting and is usually known to result in heart failures. So not only heart failures but also infective endocarditis are two very common complications which are associated with large patent ductus arteriosus. When the PDAs in size are very small, they may remain asymptomatic. But large PDAs often lead to deaths because of heart failures and also sometimes because of infective endocarditis. So B statement is also correct. C, it is a patent embryological connection that has not closed, which I just now told you. This is a correct statement. It's an embryological connection between the aorta and the pulmonary artery present from the fetal life, which should have closed between day 10 to day 21 after birth. If it has not closed, then it becomes abnormal and is known as a patent ductus arteriosus. So the only statement which is wrong is statement D. D says will require prostaglandin infusion. Prostaglandin infusions actually are given to keep the ductus arteriosus open. So they are given to keep ductus arteriosus open. What you will require in a patent ductus arteriosus is a drug to close the ductus arteriosus, not to keep them open. It's already open. You will require drugs to close the ductus arteriosus, which actually are prostaglandin inhibitors. So in the fetal life, it's prostaglandins which keep the ductus arteriosus open, along with other factors such as low oxygen in the intrauterine environment. So because prostaglandins are important for keeping the ductus arteriosus open, prostaglandin inhibitors will be required to medically close the ductus arteriosus. If it does not close medically, then obviously surgical closures are there. And in some cases, surgically closures should be the first line treatment options. But anyway, medically, a prostaglandin E1 will be required to keep the ductus arteriosus open. It is usually given to keep ductus arteriosus open in some cyanotic heart diseases, which are called as duct-dependent lesions. What would be required in a patent ductus arteriosus is a prostaglandin inhibitor to close the ductus arteriosus medically, such as indomethacin, such as ibuprofen. So these are drugs which are approved for medical closure of the ductus arteriosus, especially in preterms. So prostaglandin E1 will not be helpful in this case. It will not close the ductus arteriosus. You will give drugs such as indomethacin or ibuprofen to close the ductus arteriosus. So here, since he's asking which of these is an incorrect statement, D is an incorrect statement. Coming to question number 8. Now question number 8 says, which of these neonatal disorders is a common cause of chorioethitoid cerebral palsy? Now, in my classes, I've discussed about cerebral palsy, which is a non-progressive neuromotor disorder associated with injury to the brain very early in life. And there are various causes of cerebral palsies in children. Broadly, I told in my classes that cerebral palsies are divided up into 4 broad categories: a spastic form of a cerebral palsy, then a chorioethitoid, also called as a dyskinetic type of a cerebral palsy. Then you have a ataxic type of a cerebral palsy, and then you have a mixed type of a cerebral palsy. Spastic cerebral palsy is further subdivided up then into a spastic hemiplegia, where one half of the body has increased tone. Then a spastic diplegia, where the tone of the legs is increased to a greater extent than the tone of the arms, and a spastic quadriplegia, where both the arms and both the legs have increased tone. Now my question is on a dyskinetic type of a cerebral palsy or a chorioethitoid type of a cerebral palsy. Please remember that whenever the cerebral cortex of the brain is primarily damaged, the hemispheres, it leads to a spastic cerebral palsy. But whenever the basal ganglia is damaged, it primarily leads to a dyskinetic type of a cerebral palsy, a chorioethetoid type of a cerebral palsy. That's a type of cerebral palsy which is associated with extrapyramidal symptoms. Ataxic cerebral palsy is more commonly because of damage to the cerebellum. But dyskinetic cerebral palsy is because of damage to the basal ganglia. And one of the most common neonatal disorders which is associated with damage to the basal ganglia is kernicterus. Very high bilirubin levels in a newborn often can cross the blood-brain barrier and get deposited in the brain, particularly in which area? The basal ganglia. So kernicterus is a well-established cause of a dyskinetic cerebral palsy or a chorioethetoid cerebral palsy. A hypoxic ischemic encephalopathy or a perinatal asphyxia is more commonly a cause of spastic cerebral palsies. So, because he's asking which of these neonatal disorders is more commonly a cause of a chorioethetoid type of a cerebral palsy, the answer should be kernicterus. So, what should be the answer to question number 8? The answer to question number 8 should be kernicterus. Let us now move on to question number 9. Question number 9 is a question where they are asking a child is delivered with pulmonary hypoplasia, extremity defects, abnormal facies, and bilateral renal agenesis. I think you must have understood the syndrome. The syndrome is the Porter syndrome. The Porter syndrome is associated with a pulmonary hypoplasia. It is associated with the oligohydramnios. It is associated with twisted skin, which is wrinkles in the skin. Then it is associated with a twisted face, which is abnormal face. It is associated with extremity defects. And it is associated with renal agenesis. In our question, we have a history of extremity defects also. We have a history of pulmonary hypoplasia also. We have a history of abnormal face also. We have a history of renal agenesis also. And we have a history of oligohydramnios also. So the best answer here should be a Porter's syndrome. Best answer here should be Porter's syndrome. It is one of the most common syndromes associated with a bilateral renal agenesis, while a Vectel syndrome is more commonly associated with unilateral renal agenesis. A Porter syndrome is more commonly associated with a bilateral renal agenesis. So, because we have a patient who has pulmonary hypoplasia, extremity defects, abnormal face, bilateral renal agenesis, oligohydramnios, I think the best answer here should be a Porter syndrome. And coming to question number 10, which of these congenital heart defects is commonly present in Turner syndrome? So Turner syndrome, I've told again in my classes, is often associated with a bicuspid aortic valve and with coarctation of aorta. And bicuspid aortic valve is not one of the options given here. Therefore, the best answer should be a coarctation of aorta. Down syndrome is often associated with atrioventricular septal defects, atrial septal defects, ventricular septal defects, tetralogy of Helix. Williams syndrome is often associated with supravalvular aortic stenosis. Noonan syndrome is often associated with pulmonary stenosis, especially valvular pulmonary stenosis, and sometimes even hypertrophic cardiomyopathies, which can be seen in Noonan syndrome. Congenital rubella syndrome often is associated with patent ductus arteriosus, pulmonary stenosis. very rare to see ASD in congenital tubular syndrome. So different syndromes which can be associated with different heart diseases. Since he is talking about Turner syndrome, the most common congenital heart defect seen in Turner syndrome is a bicuspid aortic valve, but it can also be associated with the coarctation of aorta. So with this, I finish up these 10 high yield questions. I hope you have understood these questions and you have found them useful. Please remember these important topics for your exams, and I wish you all the best for your June FMG exams. Thank you and goodbye.